Well, hello and welcome to Gramedica's podcast. This is episode 1, Confidence in the Conversation. We are your hosts, Kyan Flynn and
Sheridan Geisler.
And today our guest is Dr. Ellie Daniel. He is our Director of Clinical Affairs. And today's theme, From First Encounter to Everyday Confidence, how HyProCure became a core part of clinical conversations. So thank you, Dr. Daniel, for joining us today. We really do appreciate the time you've set aside for us.
It's my pleasure. Hi, guys. How are you doing?
We're great.
We are great.
Things are moving forward here. So for those of you who may not know Dr. Daniel, can you tell us a bit more about your background? So tell us, what kind of practice do you run? What types of patients do you typically treat? Where are you located?
Okay. So basically, I've been out of school since 87. So it's been a long time, as you can see. Anyway, so I've been in the same place ever since, which is basically in the middle of nowhere, in the middle of cornfields and bean fields in the middle of Illinois, So we're about an hour and a half away from Chicago, from Rockford, from the Quad Cities, from Peoria. We're right central there. It's called the Central Illinois Valley area. So I've been practicing since about 87. So it's been about 38, 37 years, something like that. A couple of years, I'll be 40. And I've been doing all kinds of stuff. We, again, live in very remote areas. So whatever comes in the door, we have to treat. So, and most of my patients cannot really afford to travel anywhere. So they come to this area. And then you, as a doctor, you have to try and help them as much as you can. So that's basically all I have to tell you about me, except if you have any more questions. So ask away.
So when did HyProCure first come into your radar? When?
Yeah, it's interesting. It's an interesting story. There's the Midwest Podiatry Conference usually in Chicago. And one of my reps, he was coming to me and he was telling me about other things. And then he said one day, hey, there's a new product. Can I have you look at it? And I did. And then I said, I don't know if I want to do this and so on and so forth. It was a little bit of shying away a little bit, And one time I was up at the Midwest and he was there and he was like, you know what? They're doing a cadaver workshop. Why don't you come over and take a look at it? And I'm like, what time? And it's like, okay, in the evening, we have something going on up. And he gave me an invitation card. So I made an effort. I went up there and I walked in and Dr. Graham was there and he was doing cadaver workshop in one of the suites at the hotel, And I was intrigued with the technology. I was intrigued with the way and how simple the application of the unit is and how easy it is to put in. And what intrigued me the most was that it is minimally invasive, number one. Number two, you see results right on the table. As we are working, you're seeing results and it is ergonomic. And I love that about it because it fits exactly how the sinus looks, So, there's two parts of the sinus. We'll go through that later. But anyway, so it fits into the sinus tarsi and it sits perfect. And it was like, wow. I was like, okay, we've got to try this. So within a week, we had a patient in the door, It was very interesting. So that's how I got started with it, It was an interesting start with it.
So did you start with a certain type of patient population?
Yes. So basically I was playing it safe, So indications were originally that you have to have a flexible flap, flatness of the foot, not flat foot, but flatness, I don't want to call it flat foot because it's not really flat. It's flattening more so than flat. It is the process of flattening, not the actual static portion or motion of the foot. So anyway, so I was playing it safe. I was only getting the patient that was really flexible, that I could put where I need to go, put him, and that had good musculature because you need good muscles to work with, So it was a young person, it was not a child. It was like in the 20s, the first patient that we did. And we did the surgery and we got a beautiful result right off the bat. And it was like the first step and the first step was good. So the minute you have a first step and it's good, you're going to go on to the next one and the next one and the next one. And now 3,000 plus afterwards, we're still doing the next ones.
Yeah, that's great.
Yeah. So it's a good process. It's a good procedure. And that was in 2000, I think it was 2007 or something like that, 2008, something to that nature. I don't remember exactly right now. It's been a long time. So we've been doing it since then.
That is
The initial
wonderful.
users. That's great.
So, looking back from your history, what were the key moments that you would say solidified your HyProCure as your go-to device or solution rather for you, like when you're making the decision on how to treat your patient?
Exactly. So you have to pick your patient. It's always the case. You have to pick your patient, no matter what it is, right? And sometimes we make the mistake of not doing that, but you have to pick a patient. And once we started feeling how this is working on our patients, it worked out nice. It was working good. So I would give the option. I would say, hey, we didn't have options before. This is something new. We can do something with this. It'll help you out. Think of it as an internal arch support that is everlasting inside your foot. And we don't have to take it out. It is not something we have to put in and then take it out. We don't need to do that, except if it's bothering you. And it is a reversible operation. So if there is any problems, I'll just go in there, take it out without any harm done or minimal harm done, if I may say so. It was a good thing to give to our patients, because doctors, we'd like to have armamentarium in our pocket to explain to our patients, because you don't want to just say, hey, I only can do arch supports, or I only can do fusions, or I can only do one thing. I like to give my patients options. And I give them, hey, you have non-surgical, surgical, and in the surgical field, there's many, many options. And one of them is this minimally invasive surgery that we can do 15 minutes skin to skin. And you basically, within a week, you should be up, moving a little bit and doing something, and depends on the patient, there's a lot to this, but I'm just explaining the gist of it. So that's why it was like solidified that, hey, this is a good thing. I need to do that.
How many cases did it take for you to really feel comfortable giving HyProCure as one of your core options?
So I would say about maybe 10, 12, something like that. And then I start to feeling, oh, wow, this is good, because there is a learning curve to it. Preparation is very, very important. And post-op follow-up is very important. So you have to select your patient. Bottom line is knowing your anatomy, knowing exactly what you're doing, because you're doing all this under x-ray guidance. So you're basically blind except for the x-rays, you're not seeing what you're doing inside there. So you have to close your eyes and think, hey, this is what this looks like. This is what I'm going. This is what I'm doing. You have to know your anatomy. And that's where the cadaver workshops really helped for me, because it really solidified as to exactly what I'm doing. How am I doing it technique-wise and all that stuff.
I think that's maybe a really good segue into talking about indications.
Yeah.
So what are some of the most common complaints or symptoms that turn out to be tied to the tarsal instability in your patient base?
So basically, what you're looking at is biomechanics at this point. The foot is 26 bones, give or take one. But it only has one driving force, and that's gravity. Unfortunately, we live on this planet. We don't live outside. We don't fly. So we have to react to the ground, the ground reactive forces. And whoever created us was nice enough to actually give us a foot. So the foot is actually a shock absorber. That's one of the functions. And also makes us walk on Earth, if I may call it. Makes us walk on this Earth in a way that we are very gentle. We don't have to go knocking like a horse would, or any other species does, right? We have a foot that actually can transfer us from a nice heel strike to a 4-foot propulsion to a toe off very, very smoothly. There are people who can walk on Earth that have no noise at all as they're walking, because they can do that propulsion nicely, and so on and so forth. It is important that you see a patient, you find out the mechanics of them. Right. And as the patient is walking down the hallway, sometimes I can hear their rather than, okay. So right away, I'm thinking, okay, well, maybe there's talotarsal here, or what's going on? What am I doing? So, right, you don't really, sometimes you don't have to actually say, okay, now it's a time for us to do gait analysis. You really don't need to. You can just see them walking down the hall, and you're actually, and that's the best time because they're not really aware that you're doing it and they're giving you the best data instead of you telling them, hey, walk down the hall for me, will you? And then they're really walking nice and slow and all that stuff. And you're not catching anything, So you really want to watch it as they're coming in the door. So given indications, well, there is many, many things that can go wrong with the foot. Okay. The biggest thing that you see a problem with is plantar fasciitis or heel pain. That's one of the biggest ones, whereby as you're coming down to the heel, there's a lot of heel strike. And as you come down to the heel and you sway that talus, that plantar fascia medially will start to stretch. And as if you do that too much, that's when it's pulling on the skin of the bone. And as it pulls on the skin of the bone, pulling it out, the skin of the bone will inflame. And then you'll start to have pain. When patients come in the door, severe pain in my foot, on my heel, what's going on? And you look and investigate, and all of a sudden it's a talotarsal dislocation. And heel spur even sometimes, there's no spur even. And nowadays, latest data is that please do not touch the fascia. I've not touched fascia for up to 10 years. We only do it once a year, maybe, So that's what I'm saying. Things are changing, we're evolving. People are learning that, hey, biomechanics comes first. And biomechanics is the root cause of what's going on. Whether it's a bunion, whether it's a neuroma, whether it's a metatarsalgia, whether it's, heel pain, ankle problem, knee problem, hip problem, back problem. The patient is one unit and it's one kinetic chain. Don't look just on the feet. Start with the feet, but then look upwards because it travels all the way up. That force have to go somewhere, going up, going down. And it just ground reactive forces going up and down your spine. And that's how we walk. We need to get the force out somehow. And that's where you're looking at the biomechanics of the feet, the ankles, the knees, the hips, going all the way up. So from an indication point of view, it's a myriad amount of indications, not just one thing. Always, in my mind, I consider talotarsal dislocation as a possible problem. So I'm always looking to see, is that true, yes or no? And I want to make sure that people understand. I'm not looking for talipus valgus, or I'm not looking for flattening foot. I'm looking for the process of flattening, not the position of flattening.
Very interesting that you chose those two words, right? Process versus position.
Right. It's very important people understand that, because where's my hand now? It's up. Where's my hand now? It's straight. Where's my hand now? It's down. Where's my hand now? It's up. Where is it now? It still is up. But did it go down?
Yeah,
it did go down. So there was a process of going down, even though it still is up. So on X-ray, you may see that the ankles are like, it's a cavus foot, but it's still, the talus is still going through and going down. And there are things on the X-ray that you can look for, clues that tell you that, hey, this is what's going on.
What would you say in their top complaints that you see in patients?
The biggest one is heel pain. Yeah, the next biggest one is medial arch pain, like posterior tibial tendon dysfunction or peroneus longus tendon dysfunction or things to that nature, and or bunions, hammer toes. Sometimes they come in with just an ingrown toenail and you're looking at them and they're like rotating the toe over and they're touching the ground with that. And that's where the ingrown is because their talus is pushing it down. And you're thinking about it and you're like, well, I just want you to know your ankles are not stable. You really need to let the patient know what you're finding. You're the doctor. You got to let them know that that's what's happening. You don't want to do something, that's fine. At least get some arch supports, something,
Yeah.
but something.
Yeah.
And then the patient or the mother or whoever is there, father, whoever the parent is, or grandparents, whatever, whoever comes at the door with them, then they're thinking, hey, and then they're starting to tell you that, hey, you know what? I've been seeing him walking the wrong way and he comes home or whatever, and he's tired all the time. And, or, you know what? He's not being active in his school anymore. He's telling me, hey, I don't want to do anything because he's tired. Or, a patient, my back is hurting me. I just noticed that. Man, this really makes sense. You're the doctor. Your observation is important for the patient. And you are there to teach them more so than to treat. The treatment is easy. but teaching is number one.
Yeah, I would completely agree with you with that. And we found that, right? Is it's educating the patients to understand their options, right? So once you have confirmed that basically the patient has instability, what treatment options do you typically consider? And how do you decide between them?
So I always do tell my patients, I tell my doctors that I teach overseas, I go overseas everywhere to do that. So one of the things that we tell them is that always think three options. You can do nothing, you can do conservative, or you can do surgical. Three options. Not much we can do. All right. And then I go through it. Doing nothing. Hey, you can live your life like that. It's going to be problematic. You're going to have issues, blah, blah, blah. 1, 2, 3. You want to do conservative? By all means, let's start. And at that point, what I do is I tell them, let's start with some physical therapy. You know why? Because I need that posterior tibial tendon to work. Even though I put a HyProCure in there, or I put a stent in there, or I put anything in there, I need that posterior tibial tendon to work. It's functional. It needs to be functional. And a lot of these patients have dysfunction of that tendon, and it's not able to work. So they go to the physical therapist, and the therapist is trying to help them, but they can't. But even though I want some muscle, so I want them to build up the musculature, even though. Why? Because if I do the procedure, I have the muscles to support me.
Right.
Yeah.
Yeah.
That's right.
Otherwise, I do the procedure and there's no muscles. It's going to be dependent all on the stent. Well, guess what? A stent can only do so much. You got to have those muscles to work, So you really need to observe this from all aspects. So physical therapy is a big part, And so I tell them, hey, you got to do some physical therapy, get some ankle braces and or, high top shoes, good arches, all these things. We'll give them some anti-inflammatory to calm them down, whatever is going on, if we have to. Okay. Number 3 is surgical. And at that point, I have a way of telling patients is you have two options. You either do major surgery or you do minor surgery. And if I tell you that, you have two options. You have either major or minor. Which one you're going to choose?
I'm choosing minor every time.
I'm doing minor. Absolutely.
Another thing that I tell them, okay, well, I can offer you two different types of surgeries. I can offer you either a joint destructive surgery or a joint salvaging surgery. Which one would you choose?
I think I would choose the salvaging.
Yeah.
Okay. So at that point, I'm steered over to where? To doing something that is minimal on the joint, right? Okay. So at that point, I say, okay, well, I have a device that we can put inside the sinus, open that sinus up, put the device in there so as the talus doesn't fall down. I'm not touching cartilage. I'm not touching bone. It's in a ligament. So it is mobile bearing device. So it moves with you and it's there. It doesn't touch anything. And I can take it out pretty as easy as I put it in.
Right.
So that's very, very simple to do.
And I think it's really key what you said is that you give your patient the option, right? And then once they make their decision based on the options that you provide them, you're still guiding them, right, to the best outcome from their...
You have to. And I tell them, hey, if you want to do joint destructive procedures, by all means, we can do that. Don't take me wrong. It's not the carpentry. It's what's going to happen to you afterwards.
Yes. Right.
And I explain to them what's going to happen to them afterwards. All right. Whether I do this one or this one, it doesn't matter which way we go, because it's important that they understand it's their foot. It's not my foot. To make sure they understand their problem and why are we doing it. It's important they understand why we're doing it.
Yeah. And do you feel like patients are pretty receptive to that once you're giving them the reasons behind your choices or what options you're providing them?
Exactly. So most of the time you see the patient actually driving the narrative.
Very interesting. Okay.
Yeah, so at that point, the patient is engaged. They're actually talking to you and telling you, wow, is there something like that? I would like that very much if there is anything that simple. So now they're driving the narrative.
Yeah.
Even though they came in, they said, I don't want surgery, okay? Don't talk to me about surgery. I already am talking surgery, and I'm telling them this is an option. Please do not go there if we don't want to. But then they're telling me, okay, so what's the post-op? And right away, you're thinking, okay, well, maybe they are thinking surgery. That's fine. I will tell them what the post-op is. And I have a protocol that I do. And I tell them, hey, this is how it is. This first week, you do this. Second week, you do this. Third week, you do this. I have it all spelled out in a piece of paper. And I give that to them. And I show them how they should follow that paper, exactly how it should be done. And tell them that's what needs to be done. And I explain, the foot is a weight-bearing structure. You have to think that way. It's not a hand. You don't just put it in a thing and you can do your thing, But thank God we have knee scooters, we have crutches, we have walkers, we have all kinds of things that we can work with anymore. Not like we had before.
So why do you think that some physicians maybe still prefer other methods, right? Do you think it's like familiarity, training, reimbursement, or just not maybe educated? Or what are your thoughts maybe why they might not? Or they'll go straight to total reconstruction
Again,
or orthotics.
Right. So it could be a combination of things, right? I personally think education is paramount. Number one is education. And I feel like most doctors who encounter my technique, well, their primary care or whatever, they're always thinking, what are you doing again? I never heard of that before. Is it a lapoplasty? What is it again? What are you doing? And then I have to explain. So I've known that to be the case. So what I've been doing is I've been putting that in my notes before the patient goes to their primary to explain what they're doing, what are we doing. And I put it in my note that that's what I'm doing. And then I give that to the patient. And then they take it to the primary. And the primary then is looking at what I'm looking at. And they're saying, okay, interesting. I'll send them another one. And then you see the doctor sending you patients.
Okay, so you work with a primary doctor and you educate them based on you educate the primary doctor kind of.
Well, number one is the patient, right? They're walked in the door.
Right.
So they're the first person that they're getting the information. But then you have to get primary approvals most of the time. But this is how it is in this area. You have to get primary approval for you to get anything done. It's a hospital rule. There's a lot of didactics and all that stuff, logistics. So because of that, we send them out to their primary to say, hey, they're okay for us to have anesthesia. They're okay to have this kind of procedure, whatever. And then they come back and then they have the approvals. And then once you have the approvals, we move on to the next step. I don't do anything in the office. I always do things in a hospital setting. So that's why, because of that, we have to follow the rules and regulations of the hospitals that we work for.
For Daniel, how long of an education session, like how long does that take to get to a resolution or a decision by your patient?
Usually about half an hour to 45 minutes. By then, I would have looked at the x-rays with them. I usually pull up the x-rays in front of them. And I have a foot model and I'm showing them on a foot model how things are working. And I'm a person who uses their hand a lot. So I kind of like, okay, this is how it goes, this is how it goes, so on and so forth. And I'm very much an animated person. I don't just sit there. You need this, done. Okay. I'm not like that. I'm always talking and explaining, and education for me is very important for the patient. It's extremely important.
Yeah. I mean, the patient has to know what's being done to them, right? Or why you're suggesting this reason. Patient should be always their own advocate, right? So if you're not, so I 100% on board with that whole patient education and ensuring that they understand fully what is coming down the pipe.
Yeah, so number one is patient, number two is primary care, and then number three is insurance. 1, 2, 3
Right. Never forget them.
No.
How do you explain to patients or your colleagues how HyProCure specifically addresses the root cause, not just the symptom? So yeah, I guess walk me through a conversation of what that looks like, whether it's with a colleague or a patient, if you want to give me both of each, because it probably differs, I would imagine.
Right. So basically with the patient, as I just explained, I show them where the sinus is on the x-ray. And I show them on the model, hey, there's a hole here. And look at the x-ray, there's no hole. One hole, no hole. We need a hole. It's that simple.
It is.
Okay. So if the foot is like this, we have good work. If the foot is like this, we have no good work. We need to have that up here.
Yes.
And when it is up here, cartilage against the cartilage against cartilage, we're happy. But when cartilage is here against bone and this cartilage is against bone, you're rubbing and you're causing pain. And I touch them in that area and something's happening there, doc. They can feel it. Even though they have heel pain, they feel that, okay? So you're touching those areas. I touch the posterior tibial tendon insertion, they're jumping. I touch the peroneus longus insertion, they're jumping. I never thought I have that much pain, doc. How come? I'm not feeling that? Well, are you feeling it when I touch it? Yes, I am. Well, let's touch somewhere else. And then I touch them up in the leg, let's say. And I say, is there pain here? No. Well, I'm touching the same touch as I'm touching down there. But there's pain down there, right? Yes. Why is there pain down there? Because it's the insertion of a tendon that's trying its hardest to keep you up and erect. And because it's not able to get you up and make you straight, you're starting to lose the control of that tendon. And that tendon is imperative. It needs to be doing what it's doing, regardless of what you're thinking you're doing. Whether you're dancing, running, jumping, moving, whatever you're doing, that tendon is doing its job without you knowing. And if it's not working the way it should be, because the bones are out of position and they're locked in place the wrong way, we need to get those back where they should be. How do we do that? Well, we get that hole reconstituted. Doc, explain to me reconstituted. What the heck does that mean? That means that the actual hole, we put it back where it should be. And we can do that through a smaller incision that we go on the side of the ankle, go underneath the actual ankle bone, and literally jack it up.
Mm-hmm.
Yeah.
Yeah.
And once we jack it up, it's sitting where I want it to be. And under X-ray vision, I'm able to see where it's actually sitting and how it's sitting. And then I put sizers in there to see which size fits best for you. And we will do whatever we need to do to put it back in place. At that point, you're able to walk nicely. Get your hand, put it in here for me. They put their hand in here. I'm moving my fingers here and I'm moving this way, and their hand is sitting here. And I'm like, am I touching you? No. That's how the stent is. It doesn't touch you. It is there just in case you do this, and then I touch you. It's going to stop you from doing that. And then the wheels are moving, you know? Then they're asking, okay, so what happens to my big toe? What happens to my knee? What happens to my hip? And you get all these questions. You got the patient engaged. The minute you get the patient engaged, you're on to educating more. And the more you educate them, the more you have them for later, because you don't want after the fact that they come back and say, how come my foot is still walking on the side? Or how come my foot is not walking properly still because you put the whatever, you know? You have things that you need to be educated about as a doctor to explain all these things. And that's where we come in to explain all these things. And that's why this series is being done, so as we can go through that a little bit at a time.
And that's what really like today's all about, is really hearing an expert like yourself that's been doing these for over 15 years talk about having that confidence in the conversation. So we really want to really hone in on how to gain that buy-in. So what we've already heard is you spend a lot of time educating. You're spending 30 to 45 minutes really showing them and involving them in your model and putting their hands inside yours and inside that sinus tarsi. What do you do, or what's your approach to patients who may be still hesitant about even like the minimal solution when you know that probably a surgical option is probably the best one for them?
I usually tell them, you know what? Why don't we try out some physical therapy for a month or so? You know, let's do it. Yeah, let's try it out. Let's see, you know? And most of the time you get the patient coming back in a couple of weeks. It's not working, doc. It's not working. I need something different. Yeah. And I need that muscle. And I tell them, hey, you know what? Even though I want you to continue, even though, you know? So what am I pushing now here as a doctor? I'm pushing conservative, right?
Yeah, right.
And that's what I'm trying to do. I am, because it is a needed thing. You need them. You need the muscles, you know? If the talus is coming against the navicular, and the navicular has that posterior right here, okay? And it's coming right there and it's hitting it every time, all right? And this thing is slipping. That posterior is not doing the job. The posterior have to do the job before the thing slips. And it's all in timing. When is it firing? How much is it firing? Is it firing enough? Is it firing after the fact? If it's firing after the fact, you're going to get this on top, and you get this bad talus all the way down and the navicular way up, you know, and or both the navicular and the talus are down, and they're not doing their job because the peroneus is not working again. So peroneus is not doing the job. We don't have three-dimensional point on the floor. You're walking on a bicycle, not a tricycle. And we have to have that tricycle, or else we fall. You're going to flip over and fall. The talus will not have any support. Even though the posterior tubule is working, peroneus is not working. Again, that's where doctors have to understand this stuff, and they have to actually educate their patients. And I'm sure a lot of docs know this stuff. I'm just explaining to you because I want to get to the public more so than just the docs.
Yeah. Right. So we've seen you be real animated, and you've got your hands are becoming the foot, etc. What good tools or visuals like do you have in your office that really help you to explain so that the patients really understand and have confidence in HyProCure or any solution that you're suggesting?
Basically a foot model, just regular foot model. Even the models that I have, sometimes they don't have articulation at all. They just have the hole. I want something with the hole for them to see the hole. This is where the hole is. That's where I'm going, Anyway, what I'm trying to explain is throughout the years, I've had many, many, many different things or props. Let me call them props. Okay. Props help you with your making people understand, it's a visuality of the whole thing, what's happening. Okay. So the props are important. And one time we were in Florida one time, and Graham have talked to somebody, and they have done they were doing something, and they did a talus that's about this large and a calcaneus that's even bigger. And you can actually put them on top of each other. They're huge, And then he made those foamy HyProCure units that you can put in, I still have them. So sometimes I use those on patients.
My gosh, I love it.
So this is how it looks like. It goes right on top of this, and this is what it is.
Great. All right. So we want to hear like a really cool, or maybe one of your favorite like success stories, or maybe like a patient.
We just had
one
one
that
actually.
really sold on it, but then ended up being like one of your favorite patients, and they've come back and like really shared how well that this has helped them with their pain levels and being able to be active again.
Well, I just did a big video. I didn't put it out yet, but it will be on my YouTube channel. I know. So basically what I did is I had a lady come in with her son, and we did HyProCure on both his feet. And then she said, well, I have 4 sons. I said, okay. That was in I don't know when it was, about maybe 6 years ago or something, 5 years ago. I don't remember right now anymore. But anyway, so she brought the first son. We did both his feet. And then she brought me the other son. We did both his feet. We did the third one, the same thing. We did the fourth one, the same thing. Now, all of them come to me at the same time sometimes. So the other day, all 4 of them came in, and they're athletes. They're young kids. They're like in their 14s, 15s, And one of them is a goalie. The other one is a basketball player, and the other one is a basketball player. The older brother is working now, and he's older man, and he's doing very well. And they all love it, So I said, you know what? I'm going to take videos of all of you. Stand on this wall. I'm going to take pictures. And so we did pictures and videos of all of them. And it's funny because they stood in front of me on the wall as if they're just standing there. I'm taking, a confession or something. Relax, you guys. You're fine. And then I had to tell them, okay, turn around. I want to see the back of your heels. So now they're all 4 of them watching the wall.
So
it was interesting.
The same thing, all 4 of them? Or the mom was just like, I noticed it in all 4 of them. I want to put them in all of them.
Well, what happened is because she had such a good result with the older one, the older son, as she was watching, see, now I'm educating mom, right?
Right.
Because she's bringing the son. The son doesn't know. He was not old enough yet, So I'm educating mom. So now that I educated mom, she's watching the other kids.
Yep.
And she's saying, well, they're getting the same problem. I better get him in. So she got him in. We did x-rays, and lo and behold, yes, they are having the same issue, She only have boys. God bless her soul. No girl.
She only from 2 mom boys.
Right.
Yeah.
Yeah.
So, and I told her, hey, I want them all here one day, and I'm going to take a video. She said, yeah, by all means, we'll do that. I said, okay, let's do it. So yeah, I didn't put it up yet. I'll put it up in the next week or so.
Okay.
Right.
And they've...
Oh, yeah. They all are no pain. They used to have pain. And I told them to tell me on video, what did they feel before and after? Yeah. And they all had the same story, I was having knee pain, hip pain, back pain, foot pain. And now I have nothing, and they can jump and they can do all kinds of stuff, and they don't even feel it.
It's amazing.
Why? Because this thing is cartilage to cartilage,
Right.
not cartilage to bone.
Right.
Cartilage to cartilage. When you have cartilage to cartilage, joint on joint works beautiful. Deranged joint is not a good thing. You have to have joint on joint, okay? Or partial derangement is not good either. Dislocation this way is not good either. dislocation this way is not good. This way is not good. You have to have joint on joint. You have to have freedom of motion. When joint on joint is good, there's freedom of motion. Freedom of motion allows the force to move the way it should be. Otherwise, it does not.
You said that these boys were all, for the most part, athletes. What kind of a recovery time did they have?
So I usually am putting them, I have protocols, as I said before. 1 week completely off their foot, only to the dinner table in the bathroom, and assist of crutches, walker, or knee scooter. Those are the words that I usually use, and you see me telling them fast because I usually use them all the time. The second week, you're on your foot about 50%. Third week, on your foot 75%, and so on and so forth. But most of them, they're coming in on the second week and they're walking with no crutches. And I'm like, oh, why are you doing this? Well, doc, I'm not feeling anything. Well, even though, please be careful. I don't want you to cause problems, because your tissue is still healing. But then again, they're young people, and young people, they heal immensely. Yeah. They're quick. So they tell you how they're feeling more so than you tell them, So they're telling you that, hey, and the funny part is they tell me, I just used it in to walk in here. I usually never use no crutch.
Oh,
Really? Okay. And then at that point, you're like, okay, well, there's the protocol out the window. It's just there for guidance more so than to be strictly to it. You put those things down, but then it's up to the patient. Now, there is a good patient. Well, right, that's what I just explained. But then there are also, I want to be realistic, there are patients that need to be off the foot for a longer period of time. And those are patients that don't bounce back as good, or have issues. And within many, many studies that they've done with Gramedica, there's only been about 6%, as I remember, the last study or something to that nature, that we had to remove those studs. But then an MB unit, you have to remove it about 50% of the time. So this is a tremendous improvement with this technology on any other technology that's out there.
I was just thinking of like the two boys that are basketball players. A lot of people play basketball, and it's interesting. Both Sharon and I have sons, and we both think that they need HyProCure.
100%.
And we're worried that they're going to miss a sports season. But it sounds like recovery time, if they follow protocol, they're young, and the placement's correct by a great doctor like you, the recovery time might be pretty minimal.
Correct. So basically, the most critical time is that first week. The first week is the most critical time, whereby the actual ligament is hugging against the HyProCure. So the HyProCure is there, the ligament hugs around it, and it holds it in place. So now it moves with the ligament, right? So it's moving, the whole thing moves together, right? Okay. So that's the most critical time, when things are actually closing onto it, and once it closes, it's there. They can do anything they want as long as it does that. Now, I tell them sometimes, hey, whenever you're doing like side to side motion, please put on an ankle brace, at least for the next 3 months. Something just to stop this from getting out, because I don't want it to come out, and so on and so forth. So we try and mitigate possible issues. Again, most likely we will do some kind of a meeting someday, just talk about mitigation, whatever else we can do.
Yeah.
Might be the subject of our next podcast.
Right.
You never know.
So what advice would you give to another physician who's interested in HyProCure but just hasn't taken that first step yet, right? Like they don't know maybe how to introduce it to a patient, or really, I don't know, don't maybe how you felt when you first heard about HyProCure and it was introduced to you, like what advice would you give your old self or a new doc?
See, when I first came into it, I did not have enough experience. But personally, I'm a person who likes to do things. I'm not going to sit down and do nothing.
Right.
So I educated myself on my own. And whenever there was a cadaver workshop by Gramedica, I was the first to sign, Whenever Gram put anything out there, I said, I'm in, I'm coming, I paid my dues to do that, I did not go to a residency program whereby somebody actually paid me to be there.
Right.
I paid for my education.
Yeah.
Every step of the way, okay? Whatever education I got, I paid for it. Funny part is, as you are being educated by this technology, you start to see other technologies become less in your eyes, because you start to feel, I know more than this. This is not right, what they're saying. What they're saying is not correct. They need to know about what I know, and then that's how my mission started to educate. So I started to talking to people about how can we educate? How can we do this? And we started doing seminars, whether here or overseas. I do a lot of overseas seminars everywhere. So I was very involved for a long time, and now I'm hoping to get involved in it again. We'll see how it goes.
Appreciate that. That's been fantastic.
The last question is that we have is, what's one mindset shift, and you kind of have alluded to this, or, clinical habit that's helped you feel more confident in your conversations with your patients? I personally think just getting to know you, Dr. Daniel, that you take pride in your patients, right? You really want to educate them and make sure that they understand and care about their overall health, right? You're not just in there, let's treat the symptom and let's get out, right? You really want them to understand fully what they're up against and how you can help them, right? So what shift helps you have that conversation a lot more confidently?
So the word there is confidence, right? And education brings confidence.
Yes, it does.
Okay. So you educating yourself will bring you confidence, all right?
Yeah.
And no one is going to educate you. Even if I say it 1,000 times to you, if you're not receptive to it, you're not going to get there.
Yeah.
Number one. Number two, if the guy who is giving you the education is not confident themselves in what they're giving you, you're not going to get anywhere. You'll be lost.
Yeah.
You've got to have a confident person in front of you saying whatever they're saying, and knowing all the different possible problems that can happen. So as if you throw at me something, let's say, I don't know nothing, but I know a little bit, and whatever little bit I know, I will tell you.
Yeah.
Okay. So I am confident of whatever I know.
I gotcha.
Okay.
And you know this, right? You
Right.
know
I
HyProCure.
know what I know. I don't know what I don't know.
Right.
So given that level, you're at that point whereby I will tell you everything I know. Hey, if I don't know something, I'm going to tell you I don't know it, but I'll try and find it for you.
Yeah.
I'll try and go out and see if I can find it for you, but I'll tell you what I know.
Yeah.
And most of the stuff I know is because of experience, The experience comes from trying things and not succeeding first time, second time, third time, whatever it is, that takes your experience to get there. Everybody's experience level will come in at a different level. I have docs right now that I have been teaching them for 3 years, and they still don't want to do something on their own because confidence level. So you need that confidence level to go up, and education is paramount to that, I think.
Yeah. I would definitely agree with you.
And so education comes from repetition. You have to repeat stuff. My dad was on me all the time when I was young. Listen to it, listen to it, listen to it. Always listen to it, listen to it. See it again, see it again, see it again. My dad was a mechanic. So he would just show me the engine. This is how the engine works. You see this piston, how it goes up and down? That's how it goes. That's how the thing goes around. And so you get into that mode as to how I want to learn. Somebody else may know a hammer and a chisel. Somebody else may know other things, whatever your level of experience has been in your life, apply it to new technology for you to learn it, and I would recommend that you try anything you can to help you learn, whether it's us here or you're welcome to go into my YouTube channel. You can call me, you can, send me an email, whatever,
And you've always said you're very open to that, and your
Yeah, by
passion
all
is
means.
education.
Yes, by all means, by all means. Yeah, I mean, I'd rather, and I tell that to my patients too. I always give them my cell number, and I tell them, if you have any questions, text me. I don't like to talk on the phone too much sometimes because I'm busy. But if you text, I have my text in front of me, and I will respond to you by text later, when I have a minute. So text me. It's that simple. And if I have an answer, I will answer you. If I don't, I'll tell you, hey, do this. Let's see if find out. So it all depends on your level. Where are you at? Where are you going to go from there? And I decided a long time ago that I am not going to sit and do nothing. I'm going to try and learn all technology that I can.